Good morning, everyone. I'm Diane Duncan, and you all know Achima. And this morning we're going to talk about What's Next Asia, the Unpublished, the Unmissable, and the Yet Undiscovered. I'm sure I've got that wrong. But anyway, we'll start this morning with Dr. Carl Cheng, who's going to share with us histology and the 2910 nanometer laser coring device for acne scarring. Carl?
Hi, good morning, my dear friends and colleagues. I'm Dr. Carl Chen from Taiwan. Thank you for Dr. Duncan's kind introduction. So today I'm going to talk how we develop novel acne scar approaches by using 2910 core fiber lasers based on the histology findings from the combination of laser and acetone. So the co-abrasions, the coring, is original to design for simulating the mechanical coring, which can maximize the abrasion with controllable coagulation due to the stacking and coagulation blending technique. So there's two types of coring, large and small. So large is from coring mode. I call this in French, Gahon coring. And the small one from ultra is petit coring. So the large and small, the difference is not only in the diameter, but also in the thickness of coagulation. So look at the ultra mode here. You can see the thickness of coagulation is only 20 to 40 micron, which is most suitable for drug delivery. So when it comes to the deeper abrasions, such as ultra and coring, and you can see because going deep, so the percentage is less than 5% for the coverages. When it comes to the superficial coring abrasions, the coverage can range from 12 to 60% when the topical drug is combined is most useful. So for me, ultra-clear is platforms which can induce two effects. Number one, coring effect. Number two, peeling. So large coring is aimed to abrade tissue, and small coring, petit coring, ultramode is to restructure tissues and enhance drug delivery. And laser peeling for clear mode and clear plus mode is to refine the tissues and also enhance drug delivery. So the laser coring technology is applied for removing or restructure aging pathologic tissues with precise area volume to achieve the remodeling or restoring younger tissues. However, meanwhile, when the biomaterial is combined, the regeneration effect could be induced. So the slide I want to show you, in terms of precision. So the laser coring removal of the area and volume can be precise measures, depends on how much coring energy you deliver. So based on the precision to abrade tissues or remove the tissues, we can cut the skins for some redundant skin indications such as dermatocolysis. So we abrade the tissue first at first pass, and second pass we abrade the tissue and contract the tissue. So we end up to get such a great result. You can see there's an increase, decrease highs, but the protocol is more aggressive. So patient need to suffer several days swelling down times. So we go conservative protocol for here. You can see there's still increase decrease high, and also increase the palpable visual high for these cases. So we also wonder what really happened on the skin when the coring technology in combination with acetone. So we recruit some indication, acne scar, pore, and wrinkles, and biopsy was taken from the untreated area and laser area, and also area treated with the combination. So here's one of the case, perioral wrinkles you can find, and combined with plant-derived acetone. You can see on left side, there's some coagulation. At the middle, you can see the healing go faster with the acetone. And on the right side, you can see when we combine with the acetone and scalp flow, there's a new vessel, organizing vessels, which is a sign for regeneration. This is very uncommon when you apply fractional energy, you can get such a regenerated vessels. So this is the patient, you can see perioral wrinkle can be improved. Not only the wrinkle was improved, the surrounding tissue was also improved. So this is another case acne scar combined with a human derived exosome. You can see 6 weeks after. So HE stain, you can see there's fibroblast activity was increased on laser site and combination size. Meson, you can see the collagen was increased at the laser site and combination size. And also elastin, you can see elastin was so significant increase at the laser site and also the combination size. Type 3 was so amazing. You can see there's increase at the laser site and super increase at the combination site. The type 1, mild reductions, C31. Here you can see remarkable increase at laser site and combination site. TGF-beta, mild elevations, SMA, NA, MMP, mild elevations. So we also done quantitative analysis at week 6. You can see left side, the diagram, you can see compared to the baseline in terms of type 3 collagen, you can see the laser side has a 30% increase of type 3 collagens. And the combination side had 54, my friend, 54 is not 15% or 50%, so it's 54. So when you look at the diagram on the right, the conventional fractional laser, at week 66, the type 3 collagen should be declined and started to replace by type 1 collagens. But when we combine the acetone, we could still have 15-fold increase of type 3 collagen, and C31 has increased 4-fold and 6-fold at the laser site and combination size. So that the regeneration effect could be attributed to the enhanced laser assist drug delivery from number 1. The optimal coagulations that show you 20 to 40 micron. Number 2, the ablative technology, so we could have a large coverage. And number 3, the speedy delivery of laser with 5,000 hertz can induce photomechanical impact, which facilitates transcellular deliveries. So what we can learn from the histology evidence with the combination of laser and acetone, number 1, the remarkable 15-fold increase of type 3 collagen may suggest a paradigm shift toward regenerative remodeling. And second, the significant increase of elastin may restore the biomechanical or elastic property of scar tissues, and the mild elevation of TGF-beta may lower the incidence of reinductions of scar tissue at our current laser setting. And the pronounced regenerative effect may attribute to the enhanced transepidermal acetone delivery due to 2010's technology, including the formation of optical delivery channels and strong corneal peeling and photomechanical impact to disrupt the cell membrane. So when back to the scar tissue, you can see that this is done by my patients. Right side, left side, you can see the scar base that shows parallel thickened collagen bundle, but even scar edge, you can see there's still some collagen, thickened collagen bundle. So the edge was still scarring. So we propose a 3-step releva coring scarring technique. There are 3 steps. Step 1, releva means release and elevate. So by using CureJet, we can create subcision in the dermis and also fill up the space. And second, we apply the coring mode to ablate the shoulder. And the step 3, we can apply the ultra energy to restructure the tissues. And when the acetone is topically applied, we need to use coring mode to peel the stratum corneum off. So here's a 3D reconstruction show how we use CureJet with normal setting. You can see there's a dermal subcision spaces. And when we add the Juvaluc, you can see there's some material in the space. So with the material, we can elevate the base of the scars. So here show how we do it. We use CureJet to achieve the so-called releva, release and elevate, and core by apply coring mode to ablate the shoulder, trim the shoulder, and we induce the ultra mode to have the scar tissue reconstruction. And when we apply topical acetone, we can have a coring mode. So look at the before and after. You can see 1 week we could have such a great result. And at high magnification, my friend, I want to see very clearly, even for such a atrophy, whitening, scar tissues, we could turn even a normal skin appearing results only within 1 week without any significant downtimes. So we can also apply such a three-step technique to the linear depression scars only within 2 weeks. Linear atrophy scar, you can see that. And this patient has been treated with 2 times. Here you can see she has a gradual improvement in terms of flattening of shadow bar scar, and the bumping scarring has been so much improved. So you can compare before and after. So this is not a photo, impact of the photo. It's a real photo. You can see there's so much improvement just only after 2 treatments. So we believe after 4 to 5 treatments, the skin can really just look like a normal skins. So in conclusions, I think 2910 Korean technology can precise abrade and restructure, refine the aging or pathologic tissue to achieve the so-called remodeling, restore younger tissues without too much downtimes. And compared to conventional fractional type 1 and type 3 collagen transformation, 2910, when combined acetone, can show a 15-fold increase of type 3 collagen and enhance elastin and also CD31 expression at week 6, suggesting a regeneration-based remodeling. And the 3-step re-level Korean scarring as a technique can provide very, very effective approach when combined electromagnetic effect for fibrosis release and elevation with 2910 core technologies to trim the shoulder and restructure the scar tissue and enhance biomaterial delivery. Thank you for your attention.
Thank you so much. Very interesting. Very interesting. You give questions today? Okay, let's do that. Okay. All right. So our next speakers, I will call next speakers, Doctors Campos. Dr. Valeria Campos. She will share her approach for skin rejuvenations with multiple technology, with the fractional, ablative, and non-ablative. So this is a kind of new session for IMCAS Asia. What is next in Asia? But it doesn't have to be Asian speakers. So anything's new, anything like unseen or unpublished, or you shouldn't be missed, then it's going to be our session. Thank you so much for coming. Yes.
Thank you very much. It's good to clarify. Someone can think that I'm from Asia. I'm Valeria Campos from Brazil. And thank you, Diana and Achim, for this great opportunity. It means a lot for me, someone from South America. These are my conflict of interest. I'm Brazilian, as I said before, but earlier in my career, I had the opportunity to do my fellowship at Harvard Medical School. Nowadays, I'm back to Brazil, where I work in the university and my own clinic. Today, I decided, when I was invited by Cartier to be here too, I decided to talk about this wavelength that I have some experience in Brazil. I have like 20 years of experience. It's not published too much. Blame it on me. I need to do this. We are almost there. And it's like a no-ablative fractional laser. So it's looking here as a chromophore. It's there. It produces, as all the no-ablative laser, it produces coagulation, not ablation. When I want really results talking about collagen, I have experience with a lot of wavelengths, I choose the 3040, and I'm going to show why. This wavelength, compared to the 1540 or 1550, that there is much more publication in the literature, it's less absorbed by water, 13 times less. What does it mean? It means that it's capable of going deeper than the one I mentioned before. So how does it work? It's absorbed by water. Water is the chromophore. We produce this heat. It's a gentle heat. And then you have the induction of collagen. And if we look at here, what sometimes we don't realize when we are using a no ablative laser. Yesterday, someone asked me in another talk if it was capable of remove vessels. It's not absorbed by water, but by the hemoglobin, but you produce this collagen. So it means that from here to there, yes, you can reduce it. Of course, it's not the main purpose of this laser. And we can work, of course, in a gentle way that we use like less energy. But when you want to go deeper, you use higher energy. And this is the kind of coagulation you produce. So yes, you can use it for drug delivery as well. Compare this no ablative laser to ablative laser. Ablative laser has like the chromophore is more absorption. So it's not mean which one is the better or is the worst. Of course, there is the advantage. No ablative, it's safe. So I live in Brazil, South America. We have a lot of ethnic skin, like in Asia, less downtime and less risk of post-inflammatory hyperpigmentation. It's very versatile, as I'm going to show. And I do have like excellent satisfaction for my patient. But of course, I need a higher number of sessions. But on the other side, the ablative can be like less or more aggressive. Depends on. You have to play with this. I want to share with you some of my results using this wavelength for rejuvenation. Here, example of a patient, one single treatment. Of course, here, I use like high energy. Here is the same patient before and after single session. Sometimes this is a downtime of like 3 or 4 days at maximum. Sometimes in Brazil, like we don't like any downtime, so I go like though. So here, 2 sessions, we have a good results, not as good as the other one, but less energy. Here, we are talking about a downtime of 2 days. Males, this is my favorite treatment for males. Males don't like to be like with any crust or anything. So here, in order to get the results, it took me 3 sessions, but it's okay. Another patient, 2. And I like to combine this kind of patient. This patient, I treated her in the whole face with IPL, and I used the no ablative in the eyes vision. Here, the same patient. Here, a combination, last patient, that I'm going to show here, the face, using like a roller, micro needling. This is something I want to share as a study had conducted by my colleagues, my resident at the university, about rejuvenation of the lips. We treated the face, we forgot about the lips. Yes, we age the lips. They change color, and for those patients who want a filler, something more natural, it can be like a good advantage of this treatment. This is the protocol was after 4 treatments. You have like a subtle result. Now, talking about rejuvenation, what would be my tips? Numbing cream is optional, depending if you're using higher or more energy or less. So I use the fractional laser localized with like, you can choose it between 100 microthermozone or 400 microthermozone. When I want to remove more skin, I use the 400 microthermozone. But when I want to go deeper, then I use the 100, then I use more energy. This is the energy that I like to use it, and the posturation. And you can use for extra facial face areas like this neck. Before and after, this is a single treatment. Acne. Yes, it is useful for acne. It is my favorite for acne scar and even acne. My favorite indication here, females, they like look like adult, so they want some rejuvenation, they have that kind of acne. How does it work for acne? Partial photothermal destruction of the sebaceous gland and reduction in sebum. The patient feels that the skin is less oily. So this is some kind of combination you can use. You can associate, yes, you can use it in combination with isotretinoin, IPL, surgical, needling, picosecond laser is one laser that I use a lot in Brazil too, and injectable. Here, example of a patient taking Roacutan. So she had some acne that was very difficult to even take it. So I used the laser here, 3. And we know that when we are treating scar, to prevent it, the earlier we start the treatment, the less chance the patient have to have a scar. Same patient, before and after. Back, this patient take like some medication to grow the hormones. He doesn't want to take it, medication. Here we use it just localizing in each lesion. There's another patient, she wanted to get pregnant, so she didn't want on the isotretinoin, so we use this laser. And this other patient, too, just one treatment to show how the scars she used to has is better. This patient, he has rosacea as well. Here, 3 treatments. So this is the setting I use it. When I have atrophic scar, I use like more energy. And when I have a hyperpigmentation, I use the handpiece when you have more microthermal zone. So my advice is fractional area. Usually I do like the whole area. And the machine I use it has like this collimated. What does it mean? It's not fractionated. So I use localized on the pimples. Complications not common and they are transient, especially in dark skin. Not have any single case of hypopigmentation. And what I like to do is to use this combination, use like a different wavelengths, the same approach. Is this useful? Yes, it is, because like you can target more lesions. So I decided each patient what I want to use it. If I have more pigmentation, if I want more collagen, even like if they can have downtime or no, the recovery time. Now, I think like the goal is not to use this for every patient, but you have to decide which one is better. For example, this is a patient, she doesn't like the pigmentation. So I use 5 hand pieces, including the key switch. Here she is. That's what she wants. And she wants to keep the freckle as well. She likes it. This is a patient older, so I use it more like intraoral, 2940, focus more on collagen and prevention of skin cancer. And I do like LED, and I do like to use an oral medication in order to make this. And what I like to use, especially on the elderly patient, is the silicone. As you age, we know that you have less silicone, it's difficult to absorb. And the deficiency, more that you have like slower healing. And the silicone I like to use is stabilized in marine collagen molecule. I do have studies for those who want to take a deep closer on it. It's published. So this is my favorite combination. I like to use, not just, I don't have time to say, but I choose to talk about the silicone before. And I associate with lasers, even when I do peel, microneedling, I always think it's a good idea to prepare the patient before the treatment. And this is the association why I do it, wound healing, blood vessels quality, and even has antioxidant effect. So for me, that live in Brazil, it has anti-inflammatory effects that there is like a prevention of post-inflammatory hyperpigmentation and the quality of the vessels. Says, as a conclusion, this is what I do it. Before any treatment, I like to prepare my patient before, like 2 weeks, immediately after. LED, vitamin C, is the molecule I like the most to use after the procedure. And I leave here this algorithm that I have the opportunity to be part, different people from different parts of the world, in order to make easy the life before and after. I leave here the QR code for those who want to take a look at that. So thank you very much for the opportunity to be here. I'm running out of my time. So I think it's an excellent treatment for acne, scars, melasma, rejuvenation, drug delivery, and hair loss. My contacts for those who want to be in contact with me, I will be more than happy to reply. Thank you very much.
Thank you very much, and thank you for staying on time. Our next speaker, Dr. Kim, is going to talk about photothermal activation of PRP for use IV and facial combination treatment.
Good morning. Yes, Friday I already told about this MCT system, activation system, about the mechanism. So today I talk about mainly the IV therapy, because IV therapy is more unraveled. Right? So I'm a doctor, so from Korea, plastic surgeon. Before my presentation, I ask some question for you. So what exactly the platelet? Platelet is the fragment from the granular cytoplasm of megakaryocyte. There's no nucleus, and then there is some mitochondria. Platelet is doctor too in my body. So this numerous doctors living inside the body, they never sleep, never die, never take a vacation. So they travel everywhere and then searching the wound, searching some problem, searching the vascular problem, and then they treat immediately for many things like this. So today I'd like to introduce my friend platelet. This is today's main topic. So yesterday, Friday, I told about this 9 mechanism. So I today simply talk about hemostasis, the vascular hemostasis maintaining, so prevent bruising, petechia, prevent the tissue regeneration and the wound healing, and the clot formation, and the fibroblast activation, angiogenesis, and some immune system. They can have they can find the virus, fungi, everything, the foreign body, and then they can activate the stem cell, and then they can secrete the exosome or the extravascular vesicle system, so that have many growth factor inside. So I want to use that for IV injection. So they stop bleeding, repair tissue, everything. So we can inject IV therapy, the PRP system, especially the activate PRP system. This is my clinic. So I have a question. The PRP, the platelet can make some clot, but is it safe for the IV injection? The active platelet can cause thrombosis. It is a reasonable concern because platelet is make clot formation. So nobody wanted to create formation and make thrombus and embolism during the IV therapy. Fortunately, many papers have reported safe profile. However, there's a safety is depend on the processing of the PRP activation. So that is processing is important issue in my speech. Once of practice is worth a pound of theory. So I decided to become my first patient. I tried to my IV protocol by myself in the early of this year. And then IV, and then I inject my face. So you can see the left side. Very tired old man is unfortunately me, but I did 3 times of IV injection. I feel a little bit better than before. Honestly, that time, first time I was very nervous and the heart rate was maybe higher. So naturally, I started to studying more and more to survive. Let me show you my blood test at the time. Initial anxiety turned into the confidence. I began to believe that PRP IV may be one of the options for the supporting health and the rejuvenation, whole body. It may shift body regeneration and metabolism from the inside out. This is 3 sessions, IV, the MCT. The parameter is improved. So just ALT, liver function, decreased 92 to 60. The total cholesterol is dramatically dropped about 400 to the 100. And HDL, the so-called good cholesterol, increased 35 to 40s. And LDL, the bad cholesterol, decreased 100 to 34. So TG decreased 700 to 500. So I'm now studying about my patient. I did the 30 patient for the MCT system evaluation, the blood test now, and I will be published soon. On the left side is my own blood sample. It's very thick. It looks like soap because I have a high lipidemia. But on the right side, the blood appeared more clear after the activation PRP IV treatment. So I tend to wake up early now. Yesterday I drink until 4 a.m., but I wake up very early and feeling very less tired than before. These changes made by improve the liver function. The left side people right after so the medication, and then my body weight is same. My body weight 85 kilogram. Actually, I needed to weight loss and I needed to exercise. I was so happy for my result. And so my friend platelet have been working harder than I imagined. The challenge is the mechanism and the activation PRP safely for the IV use. So before the traditional chemical activation such as thrombin, the calcium chloride, the calcium gluconate can activate platelet very strong. But however, that makes the clot, right? So they tend to aggregate from the fibrin and clot, and there is some risk of embolism. So I worry about that. So for IV, I want to do the biologic activation without any chemical, and then without excessive aggregation or without the clot formation. So what is the solution? The solution is the biologically photothermal activation. So no chemical, no clot formation, just I used light and the temperature. After the centrifusion of the blood is separated into these three layers, as you know, RBC, Bopicode, and plasma. Then I collect the Bopicode, I needed to contain some RBC or some plasma. Then this Bopicode transferred into this the closed system. This is the MCT cartilage. The photothermal activation system is closed and the contamination-free environment. Then we can add the light and we can the cold or temperature. So I would like to introduce this metacell technology, MTC. MCT is a closed system, and then it's designed to stimulate platelet and stimulate the Bopicode using light, many kind of light fiber, and without any chemical. So this is we can using the 5 kind of the light source. So we can deliver the red light and infrared mainly. And we can use blue light very softly because blue light is a little bit stronger for the cell. So MCT attempt to wake up the platelet using the light. This stimulation is platelet activate mitochondria, and then mitochondria increase the ATP inside the platelet, and then platelet can start to secretion of many growth factor. As I told you the Friday, that is the concept. So why are we increase the interesting in the photothermal activation? This is the safer. It is safer than chemical activation. So when the red and infrared reach the mitochondria and the ATP production, the ATP is not just energy in this time. The ATP is acting as a signal. This is the platelet, the SEM photo. It acts like the switch the light wake up platelet. There are so many granules inside the platelet. Platelet can exude these growth factors. This is the photoactivation of PR platelet. The ATP increase, and they have some pilopodia and lamellopodia begin to extend, and then calcium signal increase inside, and then alpha granule increase. So
Can you wrap it up? Your time is up.
Oh, time is over. Sorry. So this is before and after. So, yeah. 10 minutes is too short. So there are many articles about the IV infusion, and conclusively, the traditional chemical activation forced platelet to release their content. In contrast, the photoactivation awakened the platelet very naturally with only the light and temperature. Thank you for your attention. I have another reading, so if you have some question, short question, no? Yeah, short question.
Do you want to ask a question?
Oh, no. Questions at the end because we're running behind time. Okay. Anybody have a question for Dr. Kim? Real quick, because we're running behind time.
Okay, you can ask me by Instagram. Yeah.
Okay, you can go ahead and run
There are
through
many
the next
data
one.
in my
Thank you so
Instagram.
much.
Okay.
Yeah, there's another different Dr. Kim.
Not this one. Oh, okay, come on. All right. So our next speaker will be also from Korea, Dr. Kim. Dr. Song-Hwan Kim, he will share us the innovative levator aponeurosis lengthening by using a cellular thermometrics for iotropic eyelid retractors.
Thank you. Thank you for introducing myself. Good morning. My name is Sung-Hwan Kim from South Korea. I'm plastic surgeon at Hallem University Gangnam Secret Heart Hospital. Our PRS paper described correcting upper eyelid retraction after cosmetic blepharoplasty, only with an allodome spacer graft while preserving the native levator. Double eyelid surgery is hugely popular across East Asia. With the incision method, the side effect, undercorrection, overcorrection, lesion, all come down to how the levator aponeurosis is adjusted. Here's the paradox. Edema makes the eye look smaller. Sedation hides the true opening force, resultant proportion to the surgery. So even carefully planning can overcorrect it. The eyes end up pulled too high instead of simply enlarged. That's upper eyelid retraction. Classically, retraction comes from thyroid eye disease, but in our setting is iatrogenic, overshortening of the levator after blepharoplasty. The fix is logical, lengthening the levator and that was shortened. The reed typically sit well above its ideal level. These patients get a surprise look, plus ophthalmos glare and reduced acuity, and over time, the dry eye and corneal exposure. One distinction, undercorrection improves as swelling settled, but overcorrection worsens during healing. Which is why we don't wait. The unusual 6 months delay only prolongs healing in a bad position and lets symptoms worsen. Our risk set 1 to 5 millimeters too high. We correct early while the spacer can still be adjusted during surgery. Several techniques existed: hangback sutures, conjunctival muroectomy, pretarsal mini flaps, pretarsal wrestling, and aponeurotic repair. all can work well in skilled hands. But for early revision they fall short. High skill demand, hard to dose and repeat, and simple lengthening is fragile. Most resect the elevator and fix it to the tarsus, so they can't lengthen a severely retracted reed. We wanted something simpler and more forgiving. So our aim, lengthening the over-shortening elevator with an allotment spacer, visible and adjustable throughout, without sacrificing the elevator. Retrospective research, 6 for patient, 70 operations. Here is core idea shown schematically. Figure A, we detach the elevator and rebel from the tarsus and the mural muscle. Figure B, we grabbed the allotment spacer into that gap. Crucially, the native elevator is preserved. The allotment simply bridges the gap. 5 steps for surgery. First, minimal local anesthesia with the patient blinks so we can track pupil exposure. Second, expose the elevator and separate it from the tarsal plate. Third, release the mural muscle, freaking band-like adhesions, rechecking ptosis seated after each step. The photo show complete detachment of the elevator and removal of the mural adhesions. Fourth, we sit the patient up to confirm ptosis directly and set the detached range. Fifth, we grab the we grab the allotment into elevator tarsus gap, fixed with 6-0 nylon, and form the crease with 7-0 nylon. The photo shows the graft in the place. Most cases are unilateral. Sizing is simply and proportional, about 2 to 3 millimeters of allotment per millimeters of retraction, with the final length set by the gap we sit on the detachment. Many 1 by 2 centimeter graft and 106 millimeter thick. Video, let me show the technique in the video. In this clip, watch the elevator detachment from the tarsus and mural muscles, the setting of the check to confirm ptosis, and the allotment graft after into the gap in the fix. I will narrate, yes. Result 78% satisfactory at the first correction, 12% had ptosis revised by the repeat plepatosis. 10% were on the correction and regrafted, all with wide pieces. On the right is a representative 35-year-old patient, the normalized symmetry read position at 6 months. At 6 to 12 months, the result was stable. Here, 60-year-old at 7 months and 5-6-year-old at 12 months. Pupil size was unchanged, symmetry maintained, and the allotment shows minimal stretch or shrinking. No results, no observation, and the graft becomes built in the landmark for any future reapproaches. While allotment is reliable, solid with minimal shrinkage, we preserve the native ligator rather than the using. So less damage and fewer adhesion. And it's easy to titrate and to repeat. In short, earlier rodon grafting correct post-blepharoplasty retraction simply, safely, and reproducible, while preserving the ligator. The main limited is a small single-arm series, so large comparative studies are needed. Thank you. I'm happy to take questions.
That was a really beautiful result. I have a quick question before we go on, though. It looked like you were using a fairly significant size of alloderm,
Thickness is 1.6 millimeters.
the thickness, but how about the tallness of it, the vertical height?
1 by 2.
1 by 2
two
piece?
pieces, yes.
Okay, that was really wonderful. Thank you.
Thank you very much.
Yes, our next speaker is globally well-known plastic surgeon from America, Dr. Diane Duncan. She has very extensive experiences both in minimally invasive procedure and also actually everything. Her passion is on the regenerative aesthetic and anything innovations. You can find her. So, okay, she talked about redox responsive GHK conjugated sponge spicules for sustained dermal delivery and enhanced collagen synthesis.
Thank you so much, Achima. That was a really extravagant introduction. I appreciate it. I'm a little short, so hopefully, do you have a little, oh, here we go. Now I found the box. So my topic today is really super interesting. I'll be talking about needle-free regenerative drug delivery using a covalently bonded sponge spicule with a GHK molecule for skin regeneration. So I think part of the problem with our patients is that we have a whole lot of skin boosting solutions, and very few of them are pain-free. Most of these are injectable. Some of our older regular skin treatments really count on antioxidants, simple hydration. They're symptom-based, sometimes combined with energy-based devices. But sometimes these treatments are a little bit harsh, leave the patients with downtime, or just generally not efficacious. I think the newer treatments, and we're seeing a lot of them here at this conference, are scientific, biologicals, or combination treatment based. So I think that we have a lot of regenerative actives. Peptides are pretty popular everywhere and are really pretty well documented, but the delivery system is lacking. And topicals, of course, don't get through the stratum corneum without a lot of help. And if you have needle delivery, then a lot of patients may not come back. So the spicule concept is really popular in Korea. And so for those of you from South Korea, there's a lot of literature on them. But they're not globally accepted because the premise seems a little bit DIY, do it yourself. And you can order spicules online, I checked. And basically, they're bits of marine sponge that are ground up. Usually, these spiculas are silica-rich. They act as a scaffold. They are a delivery vehicle or a poor man's microneedling device. But limitations, they're mechanical effect only. They can cause infections and granulomas. And however, they do provide a high surface area substrate for peptide attachment, and so in taking another look at these, there's definitely a solution. If you conjugate with a chemical bond any active ingredients or peptides to the spicule, then they can be delivered through the dermis without the pain of needle injections. How is this done? So the molecule GHK is not always attached to copper. So this is basically glycine, glycine combination. It's naturally occurring. And you'll see this tripeptide found in human plasma, other fluids like saliva and urine. And it's interesting, though, that we see a pretty sharp decrease of expression in GHK as we age, especially around the age of 40. It starts dropping off a cliff. So mechanically, we can covalently bind GHK to the spicule, and for this, we'll use a redox-responsive linker. So this is most commonly containing disulfide bonds, but you'll also see some diselenide bonds and thioketol groups. The redox trigger in tissue will occur when their tissue is inflamed, fibrotic, aged, or you have tumor-like microenvironments. And so you want to limit this, and because there are high intracellular concentrations of glutathione, or GSH. When GSH encounters a disulfide linker, such as a covalent bond with the spicule and the GHK, then the linker is cleaved, but only once it enters the tissue. And so at that point, you're going to release the molecule so that it can combine with copper. And it has a pretty high affinity for copper. If you look at these set of immunofluorescent slides, you'll see that the expression of GHK molecules in topically applied GHK, you don't really see much of it penetrate through the skin. With a spicule, and this is not the covalently bonded one, slides in the middle, you'll see some uptake, but it's really abundant when you have the conjugated GHK. And once the GHK is released, it strongly chelates or binds to copper. And the observed clinical effects, you'll see increased expression of collagen 1, 3, decorin, and fibronectin. And mostly it's collagen 1A1, collagen 3A1. And obviously you'll see decreased expression of inflammatory cytokines and MMPs. So the mechanism of action in the skin is basically as a carrier. You're going to get a carrier of basically in two ways. One is the peptide scaffold, and you're also going to see increased expression of therapeutic GHK copper. So the overall molecular sequence, because I had a hard time wrapping my brain around this, is that if you get the conjugated link, apply the spicules transdermally, and this is basically in a cream that you rub through your skin, mostly with vertical strokes. The GHK bond is cleaved, then the GHK goes off to bind to copper. Why would you do this when you can get GHK copper creams that are already made up? You would do this because that GHK copper bond that is in creams is very highly unstable. There's not a very long shelf life, and you're going to get a whole lot more clinical and molecular activity if you do it with the spicule bond. So the spicule isn't destroyed once this conjugated bond is dissolved. You're also going to get some mechanical influences, a little bit like an ongoing microneedling stimulus, but it doesn't go away with time. And eventually, over days or maybe a week, the spicules are extruded. So if you look at these slides, you can see skin penetration with spicules, which are the turquoise area. This is basically 2 cases of the conjugated spicules. And if you look at the penetration in graph form, you'll see the control in gray and the conjugated in teal with quite a bit better penetration. If we also look at skin density, you'll see dermal density can correlate with measurable collagen reorganization and stimulation. Room temperature stability is important, and you'll see with these products on average somewhere between 6 months and 2 years. So you have the pretty long shelf life. If we look at clinical cases, this is a patient who had treatment over a period of time. This treatment is called the glassifier, and of course we all want Korean glass skin. Here's another clinical case. You can see brightening. There are different types of serum. One is for acne scarring, one is for brightening, and one is for regenerative. So the treatment protocol, you can do this 2 ways. There's basically a home care kit, which I like because it's travel size. And you have a cleanser, and for other serums, topical creams. And then you can also do an in-office treatment, which is basically needle-free, and you prep the skin and then apply the cream with the spicules mixed together, and this is performed in the office on a once-a-month basis. So here's some references for those of you who are interested in reading more about GHK copper. I think because we're looking here only at the skin, but there are various systemic improvements that you can see with GHK copper. The nice thing about this particular modality is you don't have to inject it, and at least in the US, there's no FDA indication for injection of GHK copper, even though it works well in every system of the body. Thanks so much for your time.
Thank you so much. Thank you so much. Very interesting. Can you help again? ช่วยหน่อยได้ไหมคะ หายไปอีกแล้ว Oh, okay, come back. So our next speakers, Dr. Supasorn Vanishwet Rungrung. She's coming. Oh, okay. Because I think there's very few stage that we actually allow researcher to be on stage, and this is the one, because we want to kind of build, a new things, a new development, a new technology, new fighting. So yes. Okay. All right, then we go to our discussion. Already? So,
Ajima, I have a question for you about our last speaker who's not here.
Yeah.
Can you told me that she was very innovative and not to miss her presentation. Can you summarize what she's been doing?
I can't, but she is on about a rapid detachment of microneedling platform. So I know that microneedling is kind of is a normal intradermal delivery of a substance. It can help for many conditions. It can help for acne, hyperpigmentations, and all the anti-aging treatment. And, too bad she's not here. Yeah, because that kind of interesting about, because I saw the abstract of her research. It's super interesting. Yeah.
Anybody have any questions for the presenters in the audience?
Because
Valeria?
Yeah, please, you're a speaker. Speaker, please come up to the stage. Because of those two plastic surgeons, I think they have another lectures. Kao Sheng, he's not here. Okay, so then we are just us.
Diane, I have for you a question.
I have for you.
I have any. First.
No, it's just easy questions. Do you see differences between picking 1,550 and the one that you use?
Yes, I do. I started by using the first device I used was 1540 from Palomar,
Yeah.
and it's deeper. So I still have the 1540. So when I want more superficial treatment, sometimes I use I did a comparison between the two sides. For wrinkles, 3040 is better. But you need to be a little bit careful about the post-inflammatory hyperpigmentation.
With this one also?
Yes.
Ah,
Yes.
okay.
So I pre-treated before, and one of the things I use is the peptides. That was the question.
Which one are you using for the peptide?
With the I forgot the word in English.
GHK?
The copper-based one?
GHK
Yes,
copper?
yes, copper. Yeah, copper.
GHK copper.
Yeah,
Yeah.
GHK copper.
And I like to use it before, associate with the retinol cream,
Okay.
retinol,
Okay.
and I like to use immediately after. I think it's an excellent association.
Ah, okay. Have you tried exosome or PDRN together with the?
We do
this?
have, yeah, we do have it. It's great too. Yes, there is like an issue in Brazil about the exosome. If it has to be in integrity, like if your skin has some damage, according to the Brazilian law. But
You
we
can
do.
use it? You cannot use it?
It's done. It's
Yeah.
just not
we
legal.
do use it. It's I don't say illegal because it's such a hard word, but
Okay.
according like the registration, it's to be like intact skin.
Ah, okay.
But I have to say that I do. Don't tell the law, the offices over there.
What about PDRN? Have you been using PDRN with this?
No, I do have on my own clinic someone who is using.
Okay.
It's the
Yes.
same, and like
Yeah.
Brazil, they're kind of slow with the laws, like. But there is someone next to the door in my own office doing. I'm kind of conservative person. I do like a lot of technology, and I think this association, like you showed, is spectacular.
Yeah.
What
please,
do you
share.
like? Yeah, do you like exosomes or GHK copper better?
Such a question. Because I use more the peptides because it's easy to formulate. It does make a difference just in cream. So I use more.
Oh, this is a cream form.
Yes, yes.
Not a liquid form.
No, we do have it to use after
Okay.
the procedure, but you can prescribe. Like I associate to use at home.
Okay.
Like I showed in that paper, particular paper, this integrated skincare. I'm very fond of it. I start to prepare the skin 15 days before the procedure.
So you use more for healing, or you wanted to have other actions?
I think both work.
Okay.
I cannot say yet because we are doing like I studied. After procedure, we apply half of the face. The healing, I can say for sure that makes a difference.
Okay.
But it's too premature if I say. It looks like the side where you're using has better results for wrinkles, but it's premature. Can I ask you at the Incas Paris?
Yeah.
Like I will have the answer for you.
Okay. Yes. So, what is your experiences, Diane?
Well, in the U.S., it's really popular GHK combination with estrogen, topical estrogen, because there's some
interesting.
studies that show a really good long-term increase in skin density, dermal density, as well as reduction of wrinkles and improved hydration.
For menopause woman.
This is
For
very,
perimenopausal
very, very
treatment.
It's
interesting.
worth my trip
Yeah.
to Asia. Thank you.
The
wanna
only problem
try.
is that it smells bad, and you have to keep it in the refrigerator.
We can take it. I
That's
will do myself.
fine. Yeah, that's
But
fine.
I think it's kind of a compounding pharmacy thing.
We do
Okay.
have a lot in Brazil, so that's easy part.
I'm wondering about Spickle, because when I hear about Spickle, the first thing that I think about is whether it's irritate the skin.
It does irritate your skin going in. It feels a little bit stingy.
Okay.
But because, of course, these are sterilized spicules and they're not something that you order in a packet on Amazon, which can be done.
Okay.
I've not had anybody get anything other than a mild temporary redness.
Is it sterile? No. It's sterile. I mean.
Oh, yes, it's sterile.
Okay.
But, I've had some patients complain that it's not real comfortable. It's not, you don't want it to be real comfortable because if it was, it wouldn't work. But it's certainly more comfortable than getting poked with a needle. So I think it's a novel mechanism of drug delivery. It's patented, and the product is FDA approved. So this is something that is novel in the arena of GHK. You can't get GHK through the skin legally any other way. It does have 510K clearance as a device,
I thought
not
it's
a drug.
approved in U.S. to be injected.
It's approved as a
Yeah.
510K. It's a delivery, it's kind of like fillers or a device, even though
Okay.
we're not really a device.
Yeah.
But that's their clearance.
So what is side effect that you find in the speckle?
None other than temporary irritation.
Okay. And how do you treat it? Do you just leave it and
I
or-
just tell them it's expected, an expected side effect of treatment. Just kind of like if you had microneedling, you would
Okay.
expect it to be red and stingy for a little
a few
bit.
days? Okay, interesting. How do you have any like innovative technique to apply with this speckle? I'm sure you have.
I think, because most of what we do is surgical, energy-based, biological. There are some ways that you can further enhance uptake. I have a radiofrequency device that you can apply either using a monopolar disc, or the thing that I have is really pretty novel because you can put the provider pads on your arm, your lower arm, or your base of your upper arm, and then have one of your staff give the patient a facial massage.
Okay.
And the energy, the radiofrequency energy, actually comes out of the provider's fingertips, and it's just a lovely experience. And the warmth will increase the uptake and decrease the stinging application. I don't know if the outcome is any better, but the application experience
I
is.
think you do, because like you have this thermoporation, just by increase the temperature, you increase it. I think it's an excellent idea, and then you're doing something legal. I hear some ideas because is it today some integrity of their skin. I think you do.
Maybe also okay to apply, exosome or combine with
I think
PDRN
that's
stuff.
right.
That
Well,
would be perfect.
and I do, because we are forbidden from injecting exosomes, but if you create this micro injury, to me, it would clearly make sense
Yeah.
to apply topical exosome serum or something after the microspicules actually go into the skin and are taken up.
So that microspicle is good for skin rejuvenations and also acne, maybe?
Yes, there are three
Yeah.
formulations. One is for
Melasma?
acne. I think it definitely for melasma. The interesting thing is that you can covalently bond other molecules
Okay.
than GHK. So it may be a way to get, say, TXA through the skin or other molecules that are difficult that you wouldn't really want to inject intradermally, but might be something that you might be interested in applying to the skin legally through this drug delivery device.
Have you tried on the scar or keloid?
I have not, but I think it would be another interesting use.
Yeah, that'd be interesting. Yeah, I'd like to try, on melasma and on scar and keloid. That would be interesting. How
Be
it works.
afraid to use that acne because of it might change the environment, but for melasma definitely I think it's going to be a great idea. Increase the penetration,
Why not acne?
because there's some studies showing the integrity. When you lose the integrity, you can make it worse. For acne, maybe it work, maybe not. Like the loss of transepidermal water and the skin barrier. If anything, because there's many kind of acne. For the adult acne, I think would be great idea, but for the teenager, but we need to try.
Surprisingly, I like microneedling and exosome application for acne. It has super.
But then
it's
make with the
great
exosome
result.
because
I
decrease the
appreciate- I agree.
inflammation.
Yeah.
For
Great result.
hair, you're talking this of my friend. She works with me. She used for hair. It's spectacular, the results. Microneedling with exosome for hair. It's excellent results.
Yeah. Just right.
Melinda, do you have any comments, questions?
Any comment from the floor or questions from the floor?
I'm fascinated by the GHKCU. What are your thoughts? And you have all these injectables.
You want a microphone?
Thank you. Oh, he's chasing up here. Yeah, great talk, everybody. I was fascinated by the GHK with the spicules, and as you know, in the United States, there's a huge surge. Like all our patients are on peptides. They
Yeah.
get it from the gym, GLP-1s, but one of it is GHKCU. They call it the beauty peptide, and so everyone's like self-injecting this. So, what are your thoughts with that versus the topical? Do they enhance each other, or?
I would be really careful about injecting GHK for a couple of reasons. Some of the sources are a little bit dubious. You know, you can get them from the gym. Where does the gym get them from? Probably on Amazon from China, and then they upcharge you. And, you know, they're not produced in an FDA regulated lab. They probably aren't in like a good manufacturing facility. It's not, to me, good medical practice, even if you're a DIYer, to just buy something online and inject it systemically. But I know a lot of people do it. So I think that you called it a GHK vaccine. How is it supposed to be a vaccinating preventative thing? Or is that just a marketing term, do you think? Okay. Yeah, I think, unfortunately, a lot of the gyms in the U.S. practice medicine without a license. And they're recommending all these peptide stacks and, you know, BCP 157 and TB 500. And there is some clinical evidence that these do decrease inflammation. A lot of my patients will self-inject around the time of surgery. I think it's just really bad practice because patients get themselves into trouble and they don't know how to get out. They don't want to go to their doctor and say, you know, hey, I bought this on Amazon and I've injected it 27 times and now I'm in trouble. Or they get an infection or they get some type of allergic reaction. I know it's a challenge because everybody's doing it, yet it's not regulated or not approved. And we, as physicians, have been challenged to somehow control it, but we don't have any regulatory authority to do so. So that's kind of a dilemma.
Yeah. What do you think about the IV things?
The IV thing?
Yeah. The IV PRP, but it's activated PRP though. Yeah.
Well, and there are many different ways of doing it. You know, one of our speakers talked about PRP. I think there's something interesting because you can, of course, go out and get plasma. You can use your endogenous platelets. You know, if you're over the age of 50, are they really doing anything because they're old?
Yeah.
One of the
Right.
things about one of the products in the U.S. that is platelet derived, I know you know which one I'm talking about. Old platelets, which is what they buy platelets within 7 days of expiration to make their product. Platelets can be inflammatory. They are really good with their growth factors at the very beginning of the wound healing phase, the hemostatic phase. But they do prolong inflammation. So if you use them persistently along the wound healing phase, they really don't help. And I think that there's something called a platelet storage lesion. And so the older platelets get, the less efficacious they are. And so I haven't had really stellar experience using PRP. I know it's been around for 20 years and a lot of people use it. But my preference is to use other biologicals such as either secretome or exosome products.
Maybe you could share us about secretome. I know that you wrote a chapter about secretome.
Three now, three secretomes. So,
Okay.
secretomes are basically all of the factors that are secreted by the human body or other living things, and as you know, plants even have exosomes. But Dr. Kimbrell did a really nice chapter or paper in the journal that you and I published in, the special edition on exosomes. And so if you look for the difference between a secretome and an exosome product, the secretome products have growth factors, chemokines, cytokines, mRNAs, all sorts of other nucleic acids, lipids. But the one thing to me that really stands out secretome-wise is that there are matrikines in it. And we were talking about the matrix in another session. And if you have matrikines, these are proteins that have been created by the cleavage of endogenous proteins by your proteases and enzymatic elements, your matrix metalloproteinases, and your TIMPs, which are the inhibitors of the proteases. So this is what really generates the scaffold of rebuilding. And if you don't have a scaffold, then the exosomes are only a signal. And we need substance and signals. So I tend to like the secretome products if you're wanting to do or achieve something beyond simple inflammatory reduction.
Sounds deep. Yeah, it's
Yeah.
interesting, but really interesting. Which way did you get like the most, what do you call this, the most abundance and most efficient way to get excretome? What would be the best way to have it?
The most abundant?
Yeah.
Well, I think the most abundant expression of exosomes is if you had your own stem cell lab and you had a filtration purification laboratory there and could do it yourself, but I don't think that's really cost effective because it would have to be an FDA oversight GMP facility. And I know
Okay.
some people maybe 5 years ago were trying to do it on their own, and they got shut down by the FDA warning letters because they didn't meet the criteria for production. So you could do endogenous exosomes. I know there's some platelet-derived endogenous kits that can process them.
Which sources actually get the most effective?
Well, I don't think platelet-derived are the most effective. So
No, I don't think so. Yeah.
I would say if you had a lab that you could culture them and you had your own autologous ones. You know, the other day, the first day of the conference, there's a really interesting group, the BKK group here, and they were talking about transplantation of ovarian tissue.
Yeah.
And so
super
I think
interested,
that's
yeah.
probably the future is either
Yeah.
transplantation of your own tissue into some kind of culture medium or some sort of internal reservoir that could maintain youthful exosome source, or maybe producing your own exosomes and then banking them as a tissue bank
Yeah.
process. Umbilical cord exosomes are very popular as an illegal IV source, and I think there's a lot of work that has shown that adipose-derived exosomes are better than UC umbilical cord-derived at
Where they are
certain
legal?
things.
They are legal in Europe. Where
Which
they
one?
are legal, this
Which one?
umbilical, the exosome, like.
Oh, in Europe you cannot use human-derived.
Where they are legal? They're illegal in Brazil too.
Why are they illegal? I think a lot of it is charlatan use and
Yeah, yeah,
people
this is-
claiming, oh, we have exosomes. Well, you can get exosomes in the puddle from last night's rain outside. So it's not an untruthful statement, but
Yeah.
they're not purified, they're
Wait.
not isolated. So a lot of it is manufacturing variability. A lot of it is sterility and purity techniques.
Yeah.
There were some illegal injections in one
What
of the
they are
states in the
getting, like
U.S., and people
know.
have very unfortunate outcomes in it, and septic in the hospital. So I think that's why the overall illegality is because remember back in the day when people were doing lipo-dissolve injections,
Yeah.
and in Brazil
A
it
lot.
was
Lipo's
rampant.
tabu.
You could go to your hair salon and get lipo-dissolve
The gym?
injections. Yes, I think it's that same thing.
Yeah, I feel that. And but the product was one. Now even like come from everywhere. You don't know where this come from, and the people just get it and like.
It's like Dr. Kimbrell was talking about the peptides. People get them from the gym and they just self-inject. I think that's going to be something that there's going to be always something out there.
What do you actually get from this meeting in terms of regenerative aesthetic or regenerative medicine?
I think the possibility, one of the things that I really love about this meeting is the new ideas, like ovarian transplant, harvesting when you're young, and it's
that idea too.
wasn't that great?
Yeah.
And I also love the
Yeah.
idea of having a longevity, which is kind of a general catch-all term, but lifestyle, health, and awareness, like our version of functional medicine, but with a little bit more of a regenerative capacity. And I have yet to come up with a name, but it would be great to have some kind of class or certification.
More session and
that
class on this.
Practitioners from all over the world could have a uniform education and background.
Right. We're going to have more education on this, particularly in Kaseisha for next year. We're going to integrate more of this subject. And I think it's quite interesting when we have to treat the body holistically. For example, like when we're talking about transplantation with in the first day that we are first session that we have about longevity, and it's not just tissue transplantation, but it also can produce your own hormone by yourself. Is that fascinating? Yeah, you don't need like external hormone anymore. It's just your hormone. It's your tissue.
It would be great if you could
Yeah.
do basically pharmacologic manipulation of things that you had in your own body. Like you could upregulate and downregulate certain things
Right.
without having to take any drugs at all.
Yeah, that would be top. Okay.
Call me when
Right.
you accomplish that at Shima.
I would try it myself first. Okay, but I don't have young tissue to keep anymore. All right. Okay. I think.
Any other comments or questions?
Yeah. Okay, and I hope that the audience which actually listen to our rerun, the live webmate and what do you call this live in class live. If you can have questions, you just can drop questions, or if you meet us anywhere along the hall, you can stop us anytime. All right, I think our time's up. It's a great talk. All right, thank you so much. Thank you, everyone. Thank you. Yes, thank you. Take pictures.
Can you take a picture of the three or